Good afternoon, everyone. I'm Neil Love from Research to Practice, and welcome back to Year in Review. This is the day we talk about key presentations and publications in the past year in the management of localized hormone receptor positive breast cancer. We have a great faculty today, Dr. Hal Burstein from the Dana-Farber Cancer Institute in Boston, Massachusetts, and Dr. Joyce O'Shaughnessy from the Sarah Cannon Research Institute. She's located in Dallas, Texas. Tonight we're going to focus on localized hormone receptor positive breast cancer. As always, we may be very well, and we will be actually discussing the use of unapproved agents and regimens. So check out the package insert for various products for more information. As with all of our year in review programs, I met separately with both of our faculty when they recorded a presentation reviewing the details of the papers that we're going to talk about tonight. We really see this as a three-part program. These talks are right now in your chat room. You can click and play later on. And then when we send out the replay of the webinar, we'll include these as well. Tonight, we're going to get more into the interpretation of the trial. We're not going to get into a lot of slides and a lot of details of the papers, but maybe more where these are the papers that are discussed. You can see how many are discussed. These are really great presentations. We really recommend that you check that out. Tonight we're going to talk more about clinical implications and also research implications in terms of where we're going. Here's where we're heading. We're going to start out with a little bit of an introduction, a little bit off topic, but I've got to ask, when I saw the ODAC pronouncement last week, I'm like, I got to ask Dr. O'Shaughnessy and Dr. Burstein about this. We're going to start out with that, and then we'll get into a bunch of key topics. Adjuvant CDK, we'll talk about Ladera, of course, the big trial of the year, I think, in this arena, looking at adjuvant giredestrant and more, genomic predictors, etc. But let's just start out talking about ODAC, and you may or may not know that they had a pronouncement on two issues. We actually one was breast cancer. So the much-awaited initial response from ODAC on the SERENA-6 trial, presented as a plenary last year at the ASCO meeting, and I think everybody's familiar with that, in the metastatic setting, monitoring patients for the development of ESR1 mutation, randomized between intervening with this oral SERD, camizestrant, versus continuing. They saw a PFS advantage, and the FDA ODAC recommended 6-3 against approval. We'll see whether or not what happens with the actual approval. It's interesting that it was 6-3 because we actually had a poster at San Antonio where we did a survey of 20 investigators and we asked them, is SERENA-6 ready for prime time? 14 said yes and 6 said no, so it kind of reflects what we saw there in ODAC. But also I kind of harken back to a couple years ago when the ADC antibody drug conjugate belantamab mafodotin was up for review. It had been on the market, then it was taken off the market because of concerns of ophthalmic toxicity. ODAC recommended against approval. And at the same time, we had just done a survey of 20 investigators in myeloma, and we said, if it were approved, how many people in your practice would you have right now where you would treat right now? And virtually every investigator said yes, and the average was 5 patients. I don't know whether the FDA actually ever saw that or not or heard anything like that, but they ended up approving it. And I'm going to ask our faculty tonight a similar question in a second. But I also want to bring up the fact that, and I think this is kind of interesting as it relates to breast cancer, ODAC also made a recommendation regarding the use of capivasertib in prostate cancer. This is a phase 3 trial, the Capitella 281 study, which used the capivasertib in hormone-sensitive metastatic prostate cancer patients with P10 deletions. So this is not like breast cancer with PIK3 mutations. This is P10 deletions. Very poor prognostic marker. These people don't do anywhere near as well as most people do in this situation. They also characteristically will progress imaging and not with PSA. And they showed a pretty modest, again, just PSF benefit with the group recommended to approve it. And talking to GU investigators, most of them have never used capivasertib and are kind of nervous about it. I don't know how much that contributed to the fact that we haven't heard that much support. We were kind of surprised by that. So I just wanted to alert the audience to the fact that this was cooking, and we're waiting to see what the FDA responds. But I want to just ask two questions to the faculty, and then we're going to move on because we could talk about this the whole hour. So question number one about SERENA-6. This is like what we asked these people about belamaf and myeloma, Joyce. If the SERENA-6 strategy was available, you could use camizestrant or an oral SERD. You could get all the tests, the cell-free DNA tests for ESR1 done. Are there patients in your practice right now where you would use that? I'm going to ask that to both faculty. I'll start with you, Joyce. Is SERENA-6 a strategy you'd like to use?
Yes, I would do that. I would start monitoring. I'd probably do very similar to what they did in the SERENA-6 after patients had been benefiting for at least 6 months. I'd start monitoring every 3 months for ESR1 and then switch them over to Cami, continuing their same CDK inhibitor, because I think the longer we can keep these patients without progression, the better their quality of life. ODAC was a little critical, and FDA was as well, of the quality of life data, missing data, et cetera. But it's pretty compelling that there was a tripling of the time to deterioration in quality of life, particularly pain and dyspnea, emotional and physical functioning. So I thought the quality of life data were compelling, actually. So we could talk a long time, but the answer is yes, I would use it.
So I should also say in that poster at San Antonio, we also asked 50 general medical oncologists, community-based practice about SERENA-6, and 2/3 of them said yes. So very different ratio, almost flipped to what we saw with investigators. Hal, again, is this a strategy you think's ready for prime time, or we need to wait a while?
I would say no. So this is the second trial that's looked at the same strategy of monitoring for liquid biopsy to show acquisition of the ESR1 mutation in the absence of radiologic progression. In the first trial, the PADA-1 study, they switched from an AI plus a CDK4/6 inhibitor to fulvestrant, which most people would say, based on several approvals now, is not as good as the oral SERDs. And they still saw a 6-month improvement in PFS by switching earlier. But the SERENA-6 and the PADA-1 trial are based on a false assumption that this is the only chance you have to get the drug. Everybody who acquires an ESR1 mutation is now going to be switched over at some point to an oral SERD or fulvestrant. So the only question is there a clinically compelling benefit to switching earlier based on the acquisition of the molecular mutation without radiologic progression? And what the FDA was clearly signaling and what the voters responded to was the idea that there is no reason to necessarily switch when there's no radiologic progression. And in fact, if you look at other work that's been done, you'll see that the combination of an oral SERD plus a CDK4/6 usually gives about 10 to 12 months of progression-free survival. In the SERENA-6 trial, it was only 7 months. So it's not even clear you're getting as much mileage as with this molecular switch as you would get if you waited until radiologic progression. So I think FDA will do what it wishes. It's a weird organization these days. They just approved flavored cigarettes or whatever it was today, and they're still debating whether the measles vaccine is valuable. I don't think we can necessarily rely on the FDA for protecting the public health of America right now. But at the ODAC vote, I actually think they got that part right. And for the clinicians out there, remember, you have to monitor 10 patients every several months with molecular DNA testing to find one who might be a candidate for this approach. And I doubt that most practices will think that that's worthwhile.
So we call these surveys we do beyond the guidelines because you might have a majority who thinks something, but when you get into the granularity, it's very interesting. And I think the two of you demonstrate the fact that, at least in terms of this issue, there's a lot of granularity. Maybe the majority of people feel one way, but pretty substantial minority feel another way. So to be continued. And also, I would say parenthetically, what a challenge it is to be on the ODAC committee and to be on the FDA. I think it's easy to criticize them, but it's a tremendous responsibility and pretty complicated. But the second question I want to ask you is just actually to do a favor to the GU oncologists. This kind of reminds me a lot of what happened when TDXD got approved, the pan-tumor approval, and all of a sudden the GI people, the lung people, the GYN people were starting to go, wow, how do you use TDXD? And of course, they were asking you. And I met this morning, again, we mentioned the fact we're doing this program, or doing 2 programs at the AUA, and so I met with Dr. Raina McKay, University of California, San Diego, a great investigator we work with all the time. I was talking with her about these 2 programs that are coming up, and I asked her, how many times have you used capivasertib? And she said 0. And I think that might have a lot to do with the fact that the GU people they kind of nervous about using this new drug. Anyhow, I asked her if there's anything that she wanted me to ask you, and I just figured I'd let you see what she said.
What is their go-to toolkit that they lean on? Like whenever they're prescribing a prescription for CAPI, what's their instruction plan for the patient? Do they have a toolkit that, whether it's Imodium or other things, what's the instruction to the nurses? These patients are going to call in with various symptoms. And then what's the threshold around dose adjustment, dose modifications? There's some medications where you try to maintain dose intensity and mitigate with a lot of supportive measures. There's other medications where you start high, but you're going to rapidly dose reduce in like 70% of your patients. So you just anticipate it, you plan for it, you tell the patient you're likely going to need a dose reduction, and these are the things that would stipulate that. So I think, understanding those kind of kinetics is going to be really helpful for the GU community.
So, Joyce, last year at AUA, we showed a video of Hope Rugo at the AUA talking about capivasertib. Would you like to just maybe give just a couple of thoughts to the GU people about how to use capi?
First of all, I'd say capi is a very well-tolerated drug. There is some loose stools that you get, but then you take your 3 days off. Right when you're getting loose stools around day 3, 4, then you stop. And for the 3 days off and the diarrhea goes away. You don't really get it day 1 very much, a little bit grade 2, so it's not that much. And usually maybe patients quickly figure out maybe 1 Imodium a day or 2 Imodium days 3 and 4. That takes care of it, and then day 5, it kind of peters off. I don't think the diarrhea is a big deal. I do think rash is a thing to prevent with capivasertib, so I do think the non-drowsy antihistamine is important. I try to go BID. You can't really treat the rash that easily. You can give pulse steroids, and sometimes it works, but preventing the rash with the non-drowsy antihistamines, I think, is a good strategy. So I go BID, and then after like 6 or 8 weeks, I back it off. Like so many of our meds, the toxicity is tachyphylax. Capi is a drug patients can be on for a long time. It doesn't have cumulative toxicity. I've had a number of women on it for more than a year and a half, doing great, with their fulvestrant. And really, those are the main toxicities with it.
All right, well, let's go on now and talk about some of these papers from the Year in Review series and the Year 2 presentations. We're going to start out talking about adjuvant CDK, then we'll talk about this lidERA study and oral SERDs in the adjuvant setting, some cool trials in data in premenopausal patients, and you can see the other topics, duration of endocrine treatment, genomic, predictors, etc. So Hal, let's start out with the issue of adjuvant CDK. We saw more data coming out of the Monarch E study, now a survival benefit with abemaciclib. We also saw the TRADE study looking at dose escalation with abemaciclib and how effective that is. We also saw more data from the NATALEE study with a 5-year follow-up there. Also another study looking at whether neoadjuvant therapy or not changes the outcomes, which of course it didn't. Hal, can you talk about right now how you think about when you're going to use a CDK inhibitor, which one, and for how long?
Well, I think the data you just alluded to have been really important, and credit to the companies and the investigators for continuing very long follow-up. As you know, abemaciclib for 2 years and ribociclib for 3 years have become important tools in high-risk early-stage breast cancer. But what we've wanted to see, because of the side effects of the agents, we've wanted to see that there are durable benefits to these drugs. And I think what we're continuing to see is that with longer follow-up, the 5 to 8% reduction in the risk of recurrence has proven very durable. And now from the Monarch E trial, we have the first observation that there might even be a statistically significant overall survival benefit. So I think that speaks to the value of these drugs in high-risk breast cancers. They've done a lot of work on various clinical subsets to try and define which patients might more selectively benefit. What is important to remember is that these studies accrued a very high-risk cohort of patients. They were defined to be node positive and have other high-risk features such as high-grade tumors or high genomic risk assays. And so the population that ended up going on to this study is substantially greater risk of recurrence in the first 3 to 5 years than, say, your average American postmenopausal patient who has node-positive breast cancer. If you look at the risks of recurrence in the Taylor-X study, which is node-negative, of course, or the R-Exponder study, which is 1, 2, or 3 positive nodes, the risk of recurrence through 3-4 years of follow-up is only about 5 or 6%. If you look at the NATALEE and Monarch E and lidERA trials we'll come to in a moment, the risks are 2 to 3 times that high. So this is not your average, even your average node-positive, ER-positive patient. They've looked at all the subsets you can imagine, from astrological signs to clinical stage. There doesn't seem to be a group that they can define that uniquely benefits or not from the use of these drugs. So, again, we're using these in higher risk, higher oncotype or mammoprint assay readout, higher nodal involvement cancers. I think the gut check should be that most patients who get these drugs should also be getting chemotherapy. We don't really have data that you can use these drugs instead of chemotherapy, though occasionally I know we discuss that. But usually this is a group of women whose tumors put them at sufficient jeopardy that you'll be thinking about adjuvant chemo. And in these trials, 90% of the patients had also received adjuvant chemotherapy.
So, Joyce, a sort of follow-up on what you were saying, some of these clinical pearls that you were giving about CAPI. I'm curious about your experience in having people on abema. Do you use a dose escalation strategy, as in the TRADE trial? What do you see in people on ribo in terms of quality of life or issues that come up? And also in terms of which agent to use. I hear a lot, there are a bunch of people who would have been eligible for both trials with node-positive disease. I'm curious whether, a lot of people now are going with abema because more follow-up and survival. Are you doing that? And then are you just using ribo in the node-negative patients that would have been eligible for the trial?
So with regard to dosing, I have really started, the TRADE trial I think was very useful. It really told us if you start lower and escalate, you have far fewer women with early dropout off of the drug. I start at the 50 milligrams twice a day only for the really frail elderly or those with substantial comorbidities. Mostly I start at 100 milligrams BID. If women have no diarrhea, then I go up to 150. Most gals do have diarrhea at the 100 BID, but it's very, very manageable. And honestly, I'm mostly staying there those days. I think the data are pretty persuasive in Monarch E that patients who started at 150 went down to 100, which they tended to do pretty quickly because diarrhea comes on fast and it can be quite substantial, did very, very well. In fact, they did better because they stayed on the drug longer. So I feel comfortable. I do escalate, and those who are doing fantastic on abema, I do escalate. And so that has helped. That has made a big, big positive difference. Patients are not getting a negative experience from abema. Now, the ribociclib is extremely well tolerated. Patients have maybe a little bit of fatigue, but they have almost nothing else. We got to check the liver test. We got to check the CBC. We got to check a couple of EKGs. But in terms of how patients feel, they feel great with ribociclib. And so, what I've been doing is, for patients who are eligible for Monarch E, I treat them with abemaciclib because it's longer follow-up off drug. You know what I mean? Those curves have continued to pull apart. They're not coming back together. We're like 4 or 5 years out now from when they stopped, and now we got a survival advantage. But then I offer ribociclib for everybody else who the lower risk N1 patients and then the node-negative patients. So I use a ton of both drugs, to be honest. So that's what I do there. And let's see, was there another question, Neil? Or was that it?
No, I think that's it. You got it. Good memory. These are memory tests. You can remember all my questions. Okay. A couple quick things from the chat room, and just to emphasize too, because people are asking about the slides. Check out the presentations. We go through, but our faculty goes through all these papers that we're talking about in detail. If you want to get more granularity, check out the presentations tonight. We're really focused on clinical applications. And speaking of that, Hal, Danny in the chat room wants to know, would the faculty use abema in combination with tamoxifen in a node-negative patients who meet the entry criteria for Natalie? He has a patient who's declining OFS and AI.
So there were some patients treated with abemaciclib and tamoxifen in the Monarch-E trial because it doesn't have the liver function test issues that ribociclib has, and so it was thought to be safe. So I guess you could do it. I think you do have to be concerned about a little bit of increase in thromboembolic risk because both those agents carry it. And I think that for most patients, as we'll talk about in a moment, if they're risky enough to justify the CDK4/6 inhibitor, I must say that I think they're probably at sufficient risk that I would think about ovarian function suppression and an AI as a very important part of their treatment program. But I realize not everybody will consider all of the options that we put in front of them. And so if that's the necessary compromise, that's okay. On the issue of abemaciclib dosing, as Dr. O'Shaughnessy, as Joyce pointed out, 100 is where I start BID. And, in the Natalie trial, you remember they dropped the ribociclib dose from 600 milligrams daily down to 400 to make it feasible for the dosing. These are not drugs where there is a strong dose-response relationship. And, for instance, we know in older studies that 100 milligrams of palbo is exactly the same as 125 in the metastatic setting. As Joyce pointed out, in the retrospective analysis of Monarch-E, patients who were at abema for 100 did the same as those at 150 BID. So I would have a low threshold to run people at 100 BID if they're not tolerating the 150.
So let's go on now and talk about maybe the paper of the year, at least in hormone receptor positive disease, maybe the paper of the year in general in breast cancer, the Ladera study. It's always a lot of fun when we go to San Antonio. We usually do like 3 CME programs. So I also get the chance to ask the faculty before each program about the stuff that's being presented. The year before we had Ember 3, and I get to ask like 15 different faculty, what do they think about Ember 3? And I walked out of there pretty confused and maybe still am. And this year we had the Ladera study, and that was pretty wild too, asking everybody what they think about that. We'll ask you too as well. Very interesting, but also controversial study that Dr. Bardia presented. Joyce, can you just talk a little bit from your point of view? I'll flip through the slides, but maybe you can just talk a little bit globally about what the slide looked at. From your take, what was the most important finding? And of course, most importantly, how you see this being applied to clinical practice, particularly now with the sort of complicating issue of we've already got CDK on board here. And how do you integrate CDK as well as this? So, Joyce, what do you comments on Ladera?
Right. It was very exciting data. I thought the data were actually, the word was stunning that I used. First oral SERD in an upfront randomization versus standard adjuvant endocrine therapy. We haven't had a new class of, adjuvant endocrine therapy for, 25 years or so. These were node positive or high risk node negative patients. And, standard adjuvant endocrine therapy. Now, this is without a CDK4/6 inhibitor. The trial finished enrollment before this became the standard of care. And you can see it was quite a positive trial. And what fascinated me is how quickly the curves split. Because we know that, like, the AI is way better than tamoxifen early on. AIs are getting that resistant disease. If you've got really luminal A disease, it doesn't really probably matter if you get TAM versus AI. But if you've got an aggressive luminal B disease that's highly proliferative and kind of resistant to therapy, it recurs early. And so you can see the benefit from a better drug. And that's what we're seeing here. So this is a very positive trial. Had some arthralgias, look about the same as the AIs. I just think we need more granularity around that. It was very well tolerated. It does have a low level of bradycardia, about 10% grade 1 bradycardia. It's asymptomatic. There's no QT prolongation to my knowledge. There's nothing reported. So I think that's more of just one of those things that we note, but we don't have to worry at all about it. The issue is that it's going to be FDA approved as a single agent. They do have a 100-patient safety sub-study in combination with abemaciclib, but that's really a safety. Now, there are patients in our practice who are doing they do not feel well on their AI, and they're not uncommon, and they're on their AI CDK. And they, we don't want to give them a tamoxifen because it's going to increase their DVT risk, or they can't get it because they're on ribo. And so okay, what can we give them? And so this is going to be used. It's going to be used in combination with CDK, just because docs will be up against the wall and they don't know what else to do. Now, the Cambria 2 study is an upfront randomization to camizestrant with CDK4/6 versus standard endocrine therapy with, 30% of the population have a CDK4/6. So it's camizestrant, another oral SERD, versus endocrine, 30% with CDK4/6. So when that reads out, we're going to have a good amount of patients on the forest plot to see if there's an advantage of giving Cami CDK versus AI CDK. Now, that's not a no-brainer, because we just had the results of the first-line metastatic Persevera trial.
Right.
So look how good giredestrant works here, right? But when you put the first-line metastatic giredestrant plus, I think it was Palbo, giredestrant plus CDK versus AI plus CDK, we're going to see the data at ASCO. We're going to see the data. There's a numerical advantage in favor of the giredestrant, but it's not statistically significant. So in the context of a CDK, it can be difficult to really show enough differential benefit to have statistical significance with the oral SERD. Now, it wasn't selected, and nor is Ladera selected for ESR1 mutations, because they're very uncommon, of course, in early breast cancer. They're not that common either in the first-line metastatic, but we will see a subset analysis in Persevera. So this whole question about whether we're going to end up using oral SERDs plus CDK in patients who can otherwise tolerate AI plus CDK, is there going to be enough differential benefit of that endocrine class with CDK is unknown at this time.
So, Hal, a couple of questions. One, a lot of people are surprised to see arthralgias there. I mean, I was really excited about what you just said, Joyce, the idea that a lot of women are not tolerating AI, and at least the SERDs that we have approved right now I thought were very well tolerated. I haven't heard very much about arthralgias on at least the existing SERDs, so I'm not sure where that's coming from. So, Hal, any thoughts about that? But maybe more importantly, Hal, again, assuming you could access this, would you use it? And for example, if a patient was eligible for a CDK inhibitor, would you somehow figure out a way to integrate giredestrant? If they were not eligible for CDK, are there situations where you might want to use adjuvant giredestrant, Hal?
Well, all good questions, and I don't know that we have the answers today. Many of us were really surprised by these data. In fact, the company was surprised. This was a planned interim analysis that was done very late in the fall, and they actually had no expectation that this result was going to be available. They'd sort of submitted a trials in progress result, and then about a couple of weeks before the meeting, they got the results, and credit to the organizers at San Antonio for making this available to the audience. It was surprising, as Joyce said, because we tend to think of the minor differences in outcome between the SERDs and AIs as being most pronounced in those patients whose tumors harbor ESR1 mutations. Makes sense. Those tumors are resistant to AI therapy. But to see the observation so early was a bit of a surprise. A reminder that only 10% of the patients in this trial were treated from the United States, and you have to wonder just how many of these patients might have had overt metastatic disease at baseline that was simply unappreciated or not looked for, that accounts for some of the differences. And we're going to see tons of data in the next 6 to 12 months from multiple oral SERDs in the adjuvant setting to help us really understand better who belongs. Finally, in the stage 1 patients, which was a high-risk group of stage 1, there was no measurable benefit. I would be cautious about throwing on a CDK4/6 with giredestrant. Remember, there is a risk of bradycardia here, so I think we're going to need a lot more safety data to make sure that it's there. It's not a problem. Oncologists may have to remind themselves how to read an EKG if they're going to put patients on this drug, something we all stopped effectively doing a long time ago. But certainly provocative and not as yet published, not as yet FDA reviewed. I think it does, likely serve as a signal that in the years to come, we're going to be using a lot more of these oral SERDs. I think the data on arthralgias just speak to some of the differences between how we measure side effects and what patients tell us. We all know in clinic every day that there's a lot of arthralgias from aromatase inhibitors. When you look at the numbers here, it was exactly the same with the oral SERDs. So whether which is the accurate one, we're only going to find out when we see longer experience with this drug or this class of drugs in the early stage setting.
And again, you can check out the presentation. We go through there are a bunch of trials here. Some of these trials, a bunch of them are looking at after 2 to 5 years of initial endocrine therapy, then bringing in a SERD. So we'll see how those do compared to the other ones. I'll say, too, this is a second straight year, again, EMBER-3 and then lidERA, where they got the data. There was a press release, and somehow in 3 days they managed to get it presented. So kudos to Virginia Kaklamani. I love hearing about all this stuff when I go to San Antonio and hear from the faculty about how they scramble around trying to get this approved. All right, let's talk a little bit about a couple other things that were presented. And Joyce, one of the things I thought was really interesting was more data on premenopausal women. We saw at ASCO last year 15-year outcomes from the SOFT and TEX trials utilizing ovarian function suppression. We also saw an interesting study looking at the breast cancer index in patients. I think it was from the SOFT trial up front. We're used to thinking about breast cancer index for patients who hit the 5-year point, but this also was looked at there. And then there's going to be a new trial now. The NRG is going to do a study. Chairman Monis leading a phase 3 trial, again, trying to nail down whether or not you need chemotherapy in premenopausal women getting ovarian function suppression. So, Joyce, want to comment on any or all of these papers?
Yeah. So, with regard to the final analysis of SOFT and TEX, there is a important 4% overall survival advantage in patients in a combined combined analysis of OFS AI versus actually tamoxifen. So that's in the SOFT trial. That is a improvement in overall survival. But what's really stunning is that it really is confined to the high risk population. So the younger the women, the more they benefit from ovarian function suppression, and particularly OFS plus AI. Is crazy how poorly patients under 35 do with tamoxifen. They do tremendously better with OFS AI, but they also cut the data at less than 40, and they also see a really, really big benefit. Those women really benefit the most from optimal endocrine therapy, but also grade 3 disease. That's where they really, really saw this huge improvement of OFS AI over OFS tamoxifen. So those are some of the key. So, relatively modest survival advantages, OFS AI versus TAM and the SOFT trial in all comers. But when we really drill down into really high risk patients, very young women, and grade 3 disease, that's where OFS AI have the biggest impact. I just got to mention, Dana-Farber has this composite risk score. This is a composite that you plug in 7 variables about your patient. It comes from the SOFT and TEX analysis by Meredith Regan. It's extremely helpful. It tells your patient what her specific differential improvement in her distant relapse-free survival is going to be if she gets OFS AI versus TAM OFS versus tamoxifen. So look that up. Just Google up composite risk Dana-Farber SOFT TEX. It'll come right up. It's super easy to use. Very, very nice. So they looked at the BCI, the breast cancer index, which we usually use, right, to determine who needs extended adjuvant endocrine therapy, because it's a measure of endocrine therapy sensitivity. And they said, well, let's just take a look. They went back to the blocks of the SOFT and TEX trial shown here. They went back to the blocks, did the BCI, and you can see for BCI high on the right, now that's the endocrine therapy sensitive disease. That's the patients who do well with longer duration endocrine therapy, extended adjuvant endocrine therapy. But you can see on that previous slide that there wasn't really a difference. It was the BCI low, those with less endocrine therapy sensitive breast cancers, that differentially benefited from the OFS AI. We've seen that in the postmenopausal population as well, that AIs are just better than tamoxifen when you're on that borderline. But there's a statement that the text in the SOPT investigators have made, basically saying that tamoxifen should not be used as a single agent in the very, very young or in those with grade 3 disease. They really put their nickel down that is something they really need the OFS and AI. But, this is a super important trial that's ongoing. We probably won't have the results for about 10 years or so. But this really asks the question is, when young women who are premenopausal have N1 disease or N0 disease, where we know from the RxPonder and the TAILOR-X that they benefit from chemotherapy, the recurrence score is 25 or less, but they benefit from chemotherapy, but that's because they didn't get ovarian function suppression. Fewer than 20% of patients in an RxPonder and TAILOR-X got ovarian function suppression. So the question is, did chemotherapy really just cause ovarian suppression, ovarian ablation in those patients? And so if everybody gets OFS plus AI, and they can get their CDK if that's indicated for them, but they're randomized to chemo, no chemo. And so this is the study we need to really see whether there is a subset or not of these patients who really still benefit from chemotherapy in addition to their OFS, AI, and CDK.
So, Hal, when I think about premenopausal women, I think about your colleague at Dana-Farber, Ann Partridge, who's done so much great work in younger women. Anything you want to say about these papers looking at premenopausal women, also with the breast cancer index, and also this randomized trial? I'm curious how you're approaching patients outside a trial who are premenopausal with a recurrence score less than 25 in terms of whether you use chemo or not.
Well, the first thing to say is it's great to have 15-year follow-up from a large, important trial. And showing a durable benefit with survival advantage to ovarian function suppression is really important. Can you imagine what we would be charging for that drug if it was a commercially available patented drug at this point? The risk criteria are pretty straightforward. These are younger premenopausal women get the most benefit. Node-positive disease gets the most benefit. Higher grade, higher genomic assays. They weren't done at the time of the study, but we now know all benefit from the ovarian suppression and from the AI, which the ovarian suppression enables. By way of the point about tamoxifen, in respect to the lidERA study, a substantial fraction of the patients in the lidERA study were actually given tamoxifen. And I think it's a reminder that if anyone's going to go into these high-risk studies, it's almost unethical to be offering tamoxifen as a control arm, notwithstanding variation around the world. The studies need to be standardized here. The other point to be made is on the BCI matter, the investigators showed that there really wasn't a statistically significant interaction between the benefits of OFS AI based on BCI. So that's not a test I would look to distinguish who needs OFS AI versus other approaches. And finally, the offset study is a very important study. We're not going to know the answer to that until long after robots have replaced all of us, because no one in America is putting patients onto this trial. And so we all think we know the answer. We look at a lot of the data from RxPonder and from TAILOR-X. And with patients, we often make rational choices about what fraction of the benefit in premenopausal women might be from ovarian suppression. I think it would be great if there was more accrual for this study, but I worry that we're never going to have a definitive answer because people are voting with their feet already.
All right, let's get on to another issue that we covered in these talks. And interesting, Joyce, in the chat room, Danny just brought up an interesting question. Any role for extended ovarian function suppression beyond 5 years? And that's a good lead-in to this next topic that was reviewed, looking at the BCI. This is a registry study looking at the impact in clinical decision-making at the 5-year point or decisions regarding evaluations, as well as a new assay presented at San Antonio by Dr. Mamounis, the SET ERPR assay to predict benefit. Joyce, can you talk a little bit about, first of all, BCI? And we saw some more data from this registry study. It was really interesting in terms of what happened in terms of decision-making. A significant fraction of people changed what they were thinking of doing once they saw the breast cancer index. How are you approaching it? Do you use a breast cancer index? In what situations? And any comments on this data, Joyce?
Yeah, I do use the BCI in situations where I have equipoise about whether it's reasonable to stop the endocrine therapy or would the patient benefit from another 2 to 5 years. There are some times I think, no, you absolutely do not, as you're extremely low risk, or absolutely you need 10 years. And I'm not going to send the BCI if I feel strongly one way or the other, but there's plenty of node negative patients or even one node positive patient that's a patient who's been very adherent to her therapy. She's got lifestyle factors that really are in her favor. She exercises, her weight is stable, she doesn't drink a lot of alcohol. So there are patients that I feel they could even stop. So I do use it. It's judicious. But in the BCI registry that we are part of, about 41% of the time, doctors changed their mind. They said they were leaning towards giving extended adjuvant endocrine, and half of the time they switched to feeling comfortable not doing it. And then for those that said they were not going to do it, they were going to be comfortable stopping. I think about a third of the time they said, no, wait a minute, no, we're going to go ahead and give you some more. But both patients and physicians felt more confident in their recommendation based on the BCI results. So I do think there is a role when there's equipoise and you're looking for more information.
So, Joyce, what about this question from the chat room with Danny about extending ovarian function suppression? Do you do that?
Sometimes. So, in the softened text, they stopped at 5 years, and it was a minority of patients that had a BSO. Most got their LHRH agonist. I would like to see a subset analysis from softened text looking at those who had a BSO versus those who had 5 years and stopped. The recurrence risk continues out 15 years, but there's not a sharp drop off, in terms of DFS patients getting really worse when they stop it. But so we really don't know the answer. I will point you to a yet unpublished oral presentation from a few years ago by Sir Richard Gray, who's now deceased. He did a meta-analysis of all the OFS, OA trials, and in that oral presentation, he's got this one slide where he puts the OA versus not trials, and then on the same slide he puts the OFS versus not results. And of course, both are very strongly positive. They're not compared head to head, so that's the big caveat. But in the OFS trials, even though getting OFS was a lot better than not getting OFS, the risk of recurrence just keeps that inexorable rise over time. Whereas in the OA, the risk rises because there's some patients that are not sensitive to endocrine therapy, but then there's this sort of intriguing plateau of recurrence. It's much more blunted. So, when patients are very high risk for more nodes, I recommend oophorectomy for those patients. And, if patients have substantial risk, and then, because we can get, again, the Dana-Farber composite risk, it gives you what their risk of recurrence is. It also gives you the differential benefit from the OFS, but it tells you what their risk is. So you can really very much see how these variables impact their risk. And honestly, if they're quite high risk, I generally will counsel towards consideration of BSO, of course, if the family is finished, of course, because I'm a big, the positive trial is very helpful, and patients can take an interruption and have a child, but then I want them to get back on it again. So I tend to lean towards longer duration in these patients, but in the very high risk patients.
So, Hal, any comments on these papers? Also, on this new assay, the SET ERPR assay to predict potentially benefit from extended therapy. Any thoughts about whether that might have a future role? Also, Charles in the chat room wants to know whether you check ovarian function while on ovarian suppression. He says sometimes people in their early 50s are on several years of suppression. Do you stop them and see whether they're still suppressed? Do you check younger patients to make sure that their ovaries are actually getting suppressed, and how often you do it? Any thoughts in general, Hal?
Well, first, on the testing, we don't routinely do that. The only situation would be if you're really trying to figure out if a woman who's had multiple years and is now in the 49 to 53-year-old age group remains. But you have to stop the drug for several months to even figure that out, because otherwise you're just getting the drug treatment effect. So we don't routinely measure estradiol or FSH or LH levels. They're just not informative. They weren't done in the studies. And usually the women will tell you if they're feeling less than fully postmenopausal, and you can respond to that clinically and at that point check. There was a very nice paper in the deck that we discussed where our own group looked at the institutional experience with extending ovarian function suppression. This was not a randomized trial, but there was a large cohort of premenopausal women. Some of them continued ovarian suppression beyond 5 years, and some of them stopped at around 5 years. As you might expect, the women who stopped at around 5 years actually had what would be anatomically lower risk cancers. And so the clinical thinking was they could probably end their ovarian function suppression. And so there were higher risk cancers in the group that continued ovarian function suppression. Interestingly, the ones who continued ovarian function suppression did better. And so I think that for most women who need ovarian function suppression, continuing it indefinitely, subject only to the wish to have other children, the tolerability of the regimen, probably makes a lot of sense. In terms of the SETI assay, Fraser Simmons has done so many remarkable things in breast pathology. This is one of them. He has really developed a strong signature of endocrine sensitivity and showed that it correlates with a lot of response in the neoadjuvant setting and elsewhere. I think we can use that information to guide it, but it is not a routine test. We rarely use the BCI for deciding about extended endocrine therapy, and that's because of two things. One is usually we know the answer based on patient tolerability and anatomic stage and other risk factors. The other is that almost every patient where you might be considering this would have also had some other genomic assay at the time of diagnosis, be it the Agendia mammoprint assay or the Exact Sciences Oncotype DX recurrence score. Those tests do not predict duration of therapy benefit, but they are set up to predict absolute benefit, absolute risk at 10 years. So you can look at that and you know that if the score was really low, the risk of recurrence at 10 years, and by inference, their prognostic value of any longer therapy becomes very low, because the likelihood is they're going to do fine.
I was listening to a podcast this morning with the head of the Supreme Court, Neil Gorsuch, and he's talking about the constructionalists or the institutionalists or whatever. And I have the feeling that between the two of you, like one of you's a constructionalist, the other one's a institutionalist or whatever it is. But hey, it's always good to get a little bit of a flavor, and I'm sure we'll get some here. So before we actually get into some of these papers on genomic predictors, I just want to take a breath and first just ask what you all are doing in your practice. When you write, and of course, obviously, these questions have been out there forever, but they keep changing as we get more and more data. I'll start with you, Hal. Right now, how do you approach the use of genomic assays in your practice? Are you using, of course, obviously, the two that are most used are the recurrence score and the mammoprint. Do you use both? Do you just use one? And what situations do you use it? Any unanswered questions you want to see addressed? Any general comments, Hal?
Well, we use them every day, and institutionally, we have an arrangement where we use the Exact Sciences recurrence score, the Oncotype DX recurrence score, for cancers that are 1 centimeter or larger and have either no nodal involvement or up to 3 affected lymph nodes. And so that's a reflexive thing. It's done automatically by the pathology service. I think one of the newer innovations to that has been a look at the higher scores, and Joyce has been a lead investigator for this work with the mammoprint assay. And I've been pretty persuaded that that result that she has shown, where the high 2 scores or very similar data from Terry Mamounis and the NSABP looking at Oncotype DX recurrence scores greater than 30 suggests that not just do they need chemotherapy, but there's probably a benefit here for anthracycline-based chemotherapy in appropriately selected patients. So these assays remain the cornerstone of our thinking for the majority of women who are diagnosed with ER-positive, node-negative, or lower-risk node-positive breast cancers.
So, Joyce, I think my whole team will remember at the San Antonio Breast, after one of our programs, we sat down with you and we said, hey, can you tell us a little bit about this Flex registry you've been involved with? And the next thing we knew, you pulled out your computer. It was like an hour later. It was just totally fascinating. I don't even know where to begin, but maybe you could, again, just talk about, before we get into some of the new data, just globally, how you approach genomic assays. Are you just using MammaPrint? Do you use MammaPrint and Oncotype? And again, what situations, Joyce?
It's pretty nuanced. I really do think about it for each individual patient, what I think is best. So first with MammaPrint, if I'm sure the patient needs chemotherapy, I'm going to recommend it. Then I'm uncertain if she needs an anthracycline or not, I am sending MammaPrint and a blueprint. On the other hand, if she's very low risk, I am definitely not going to be offering her chemotherapy. I might send a MammaPrint because if she comes back ultra low risk, we have some decent data that those patients may do fine with 2 years of therapy. I'm going to recommend 5, but in case she doesn't tolerate it, from the NRG and from B42, the NSABP, and other trials in the MammaPrint low risk group, that's the group that benefited from extended adjuvant endocrine therapy. So MammaPrint has gone to giving us more information than the chemo, no chemo question. So when I have questions in that department, then I will, and those questions, I'll get MammaPrint. Now, the Taylor X is very nuanced in the premenopausal node negative population. I tend to use Oncotype for those patients because you've got the super low risk under 11, you got the 11 to 15, you got the 16 to 20, you got the 21 to 25. I treat those differently. I start bringing in the chemotherapy at the 21 to 25. For the 16 to 20, I'm going to go OFSAI. Then I'm going to go tamoxifen for the lowest. So I have a whole way I approach that. It gives me the granularity and the understanding of the endocrine therapy sensitivity of this cancer. So I tend to use that. And then I will tell you that if a patient has one positive node and she's got really endocrine therapy sensitive looking cancer, ERP 100%, it's Ki67 is 5 to 10%, it's grade 1 or grade 2. And she is a postmenopausal patient, the Oncotype has more low-risk results than the MammaPrint. So if I need a low-risk result, I will get an Oncotype. If a woman needs chemotherapy and she doesn't want to take it, then I'll send a MammaPrint. It's more likely to come back high risk. It really is true. With the same blocks, you have a little higher chance of getting a high risk score with MammaPrint and a little higher chance of getting a low risk score with a recurrence score. So I'll sometimes get those. And then in the premenopausal woman, again, one node is this whole question we were talking about, the offset. What do you do with these patients with chemotherapy until we have the results of the offset? So if somebody's like one node positive and it's grade 1 or 2, very strongly endocrine therapy sensitive, very likely with her whole profile there. I'm comfortable really probably either one, MammaPrint or Oncotype. I've got equipoise there. Again, more likely to come back low risk if you send the Oncotype, and I'm looking for the low risk. If I think the woman is going to really end up working with me and being adherent to her OFS AI, of course, I'll give her CDK4/6 inhibitor because I'm not giving chemotherapy to all those patients.
So note to self, understatement of the year, Joyce O'Shaughnessy. I have a nuanced approach to this. Just kidding. Okay, let's just talk about a few other papers.
I'm a splitter, not a lumper.
That's for sure. Okay, so let's just pick out a few of the papers just to see anything you want to say about it. Hal, these are several papers that Joyce reviewed related to the recurrence score, one looking at sentinel node biopsy and outcome, another looking at more from the RS-Clin test or evaluation, and then an AI model, of course, from Joe Sperano looking at the Taylor X study. Any of these papers get you excited there, Hal?
Well, on the sentinel nodes, there's actually a discussion these days about patients who have a positive sentinel node. Do they need an axillary node dissection to see if they are candidates for adjuvant CDK4/6 inhibitors or for chemotherapy? And I think we should resist that temptation. In most of the patients who have lower risk, 1-2 positive nodes out of several, the yield of finding a lot more nodes is pretty low. And I think you can make a good clinical decision based on the biologic information available plus the stage. On the issue of pathology and artificial intelligence, it's coming. I think that we're seeing more and more that pathology will be all digitized, that this will be then reviewed by an AI and a human. This is not going to be a surprise. There are all sorts of things on a stained slide that pathologists intuitively integrate into a risk assessment of grade, of Ki-67. The AI modules will have no problem picking those things up, I'm sure. So I think it'll be a complement to what traditional pathology review is going to show us. So that's all to be coming. And one of the questions for the profession is AI going to make pathology into a kind of almost work from home specialty in the same way that radiology is becoming one where you just sort of get the images and then sort of distribute them broadly? That's a real question, I think, for what's coming up.
So final comment from Joyce related to neoadjuvant therapy. We see a study here from ESMO last fall looking at neoadjuvant ribo plus endocrine therapy. Another paper published in Clinical Cancer Research, neoadjuvant abema in breast cancer. And then I always love preoperative window of opportunity studies, and this one was with giredestrant or tamoxifen. Joyce, any of these papers you want to comment on?
They're very interesting. I think we're not at the point where we can say we're going to give optimal endocrine therapy plus CDK4/6 inhibitor therapy instead of chemotherapy. For these cancers that really are sensitive to chemotherapy, you get higher path CRs with chemo than you do with endocrine therapy plus CDK4/6. There is a trial going on in Germany by the West German Study Group called the ADAPT cycle trial, where patients they have a lower, they get a recurrence score under 25, but they're chemotherapy candidates, but they're not the high risk individuals that we got to give chemotherapy to, even anthracycline chemotherapy, but they're randomized to 4TC versus CDK4/6 plus optimal endocrine therapy. That's a great trial, and we really need that level of evidence. So there's the only time I use AI plus CDK preoperatively is in a patient who really has to have cytoreduction. She's inoperable. She's got to have cytoreduction. And I've already sent a 21 gene recurrence score is what I usually use in that context, and it's low risk. I'm not going to end up recommending chemotherapy for her. And she's a candidate anyway for CDK4/6. She's going to get 2 or 3 years anyway of a CDK4/6. So I'll start it preoperatively to get, cytoreduction, and then she can go to surgery. So stay tuned. I think there will be a subset of patients that will not benefit additionally from chemotherapy when they get OFSAI or optimal endocrine therapy plus CDK4/6 inhibitor therapy. We'll see that from the offset trial, but also the ADAPT cycle will tell us a population we can not do chemo and just do CDK4/6 inhibitor therapy.
So Joyce and Hal, this is about the quickest hour I've been through in a while. It just sort of breezed right through it. We could go for another hour for sure, but thank you so much for working with us today. Thanks for doing the presentations as well, and I hope the audience checks out because they're really fantastic presentations. Thank you to the audience also for tuning in here tonight. Be safe, stay well, and have a great night. Joyce, thanks so much. Hal, thank you so much.
Absolutely.
Have a good
Thank you,
one.
Neil. Great program. Thank you, guys. Bye-bye now.